Hi guys, welcome back to BROMED Lectures. In this video, we're going to cover parathyroid hormone diseases. So let's begin with hyperparathyroidism, and let's begin with the etiologies. It is going to be divided into primary, secondary, and tertiary. And the vast majority of the cases, around 90%, are going to be primary in etiology, and it is safe to say that most of them are going to be adenomas, around 80% of them, with around 20% of them being hyperplasia of the gland. Now, remember the associated MEN syndrome, the type 1 with the 3 Ps, which is parathyroid, pancreatic, and pituitary tumors, and the type 2A, which is medullary thyroid cancer, pheochromocytoma, and hyperparathyroid hyperplasia. Now, the secondary hyperparathyroidism is going to be an appropriate response to hypocalcemia. So this is a response of the PTH. The PTH is being secreted because the patient has hypocalcemia. Now, you're going to measure calcium. It is going to be low. You're going to measure phosphate, and it is going to be either low or it is going to be elevated. If it is elevated, then you suspect chronic kidney disease, and you assess for kidney damage, okay? Now, for the tertiary, these are usually patients that have long-term secondary hyperparathyroidism, and now the gland has a loss of response to calcium, and it is actually responding autonomously. So keep in mind that most of them are going to be primary. Remember, most of them are going to be adenomas, the MEN syndrome associations. Secondary hyperparathyroidism is usually an appropriate response. If you have elevated phosphate, then suspect CKD. And tertiary causes are usually due to long-term secondary. The patient develops into an autonomous, irregular response of the parathyroid gland, okay? Now, for signs and symptoms, half of your patients are going to be asymptomatic. And because of this, you usually diagnose hyperparathyroidism because you check for something else, or the patient has non-specific symptoms of elevated calcium. Now, this thing, the osteitis fibrosa cystica, some patients develop into it. It is due to the increased rate of bone resorption, and it is, of course, going to generate signs and symptoms of this bone resorption. The patient is going to have bone pain, swelling, deformity of bones, fractures, bone cysts, and you're going to see it as punch-out lesions on imaging, okay? Now, for the calcium, remember, these are the patients, the mnemonic we talked about in the last video, the stones, the patients develop into nephrolithiasis, bones, all of the things mentioned in here, psychiatric overtones, the patient may have CNS problems, psychiatric disorders, obtundation. Now, these patients may develop polyuria and polydipsia, and they may develop dehydration and also constipation, vomiting, pancreatitis. Remember, hypercalcemia generates pancreatitis. Pancreatitis generates hypocalcemia. Ulcers, hypertension was mentioned, and also short QT. Remember, hypercalcemia has an increased rate of repolarization, so the QT is shortened. And in hypocalcemia, the other way around, the QT is prolonged. Now let's move on to diagnosis and treatment. And remember the different etiologies. For primary hyperparathyroidism, you're going to have elevated PTH, elevated calcium in response to the PTH, and of course a low phosphate also in response to the elevated PTH levels, okay? Now, secondary, you're going to have elevated PTH. Remember, this is an appropriate response to hypocalcemia, so calcium must be low, and you can either have low or elevated phosphate, suspect CKD. Now, other differentials, if you have hypercalcemia and you have your PTH low, then you should suspect that something else is causing the calcium to rise, and now you suspect these etiologies: malignancy with a PTHrP hormone, and also granulomatous diseases or other malignancies with metastasis to the bones, for example. And the other differentials according to hypercalcemia. Now, the treatment, remember, always determine if the patient is in a severe state meaning more than 14 milligrams per deciliter in concentration of calcium, and symptomatic patients, okay? All the symptoms we mentioned earlier. These patients require saline hydration immediately, evaluate for the addition of calcitonin to further lower the calcium levels, and evaluate for the need of loop diuretics. Never add loop diuretics if your patient is dehydrated. Now, you may consider surgical removal if the patient has primary hyperparathyroidism. Remember, most of them are due to adenomas or hyperplasia of the gland, and by removing the glands, then you get rid of the problem. So there are certain criteria that you need to take in order for you to perform this procedure. The first of them being that the calcium concentration is already higher than 11.5. These patients require that you take away the parathyroid. Now, renal insufficiency patients that have age less than 50, because they have a more chronic state, they're gonna eventually develop into problems due to the calcium, and nephrolithiasis if the patient is already having symptoms, osteoporosis, osteitis fibrosa cystica, etc. These are because you can remove the gland and get rid of the problem, and you're going to avoid the patient to develop into something else than just a tumor, okay? Now, these patients may develop into hungry bone syndrome, and this syndrome is because the patient was in a hyperparathyroid state, and now you get you get away the gland, the PTH is going to drop, and now their bones are hungry, they are avid for calcium, and the patient is going to develop into hypocalcemia, increased osteoblast activity. The magnesium can go down, the phosphate can also go down, and it usually develops 1 to 4 weeks after. Look for it for the patient that has surgical removal of the parathyroids. Now, for medical management, remember to lower calcium intake, hydrate your patients always, and bisphosphonates. This is going to be for the patients that are not in an acute severe more than 14 milligrams per deciliter or symptomatic state of hypercalcemia. For these patients, remember, regulate their calcium, hydrate them, and bisphosphonates is the correct answer for chronic management. And now let's finish with hypoparathyroidism. For the etiologies, your number one cause is going to be surgical removal of the gland. And so remember that these patients develop hypocalcemia if you do not replenish calcium and you're not aware of the PTH levels in these patients. Also, there's been description of hereditary causes. Some infiltrative diseases such as sarcoidosis, amyloidosis may infiltrate the gland and produce hyperparathyroidism. Patients with DiGeorge syndrome, this syndrome is important because these patients have a lack of development of the third and fourth pharyngeal pouches, and so they're going to have lack of PTH, lack of thymus, so they're going to develop immunodeficiencies and hypocalcemia. There's also other associations with this syndrome, with especially cardiac abnormalities, so keep this in mind. Hypomagnesemia, remember magnesium is a permissive hormone for the secretion of PTH. If you don't have magnesium due to alcoholism, malnutrition, or diabetes, then these patients develop hypo-PTH and hypocalcemia. Signs and symptoms, tetany, remember that calcium is a membrane stabilizer, and if there's no calcium, now your neurons are going to have a lower threshold for depolarization, and so the patients may develop tetany, cramping, spasms, the Chvostek sign, the one of the percussion of the mandible, the Trousseau sign, the one of the arm with the blood pressure measurement, now seizures, and also this one, QT prolongation. Remember, the low calcium is going to generate QT prolongation, hypercalcemia is going to generate QT shortening. And this one is due to low calcium levels. Then you have low calcium for repolarization, and so your QT is going to prolong. And also cataracts have been described although the exact mechanism is not known. Now, for the diagnosis and treatment, it is the same as for hypocalcemia. First, correct calcium with the formula we talked about in that video. Correct for the albumin to see if it is a true hypocalcemia or if it is only an hypoalbuminemia. Check magnesium. If it is low, replenish magnesium. Ask for recent blood transfusions. If the patient has blood transfusions, then it may be because of citrate. If the patient is symptomatic, give high B calcium. And lastly, check PTH to see where you're at and to pursue a diagnosis.